In terms of defining progression, in clinical trials, we use the RECIST criteria, which is essentially any new non-target lesion or 20% or greater growth of a target lesion that you're. But in your typical clinical practice, it's more of a subjective call. If you look at the NCCN guidelines in terms of gauging whether to switch therapy, because that's really what you're looking at. It discusses dividing patients into symptomatic versus asymptomatic. Now, I think obviously a lot of us, we don't wait for patients to develop, worsening shortness of breath before switching them over. We like, to try to get a response and get benefit before it gets to that point. So some of the things that I look at is the bulk of disease and the tempo of disease. And I think most oncologists look at that as well. So, where I think about switching therapy based on progression is when there's a high bulk of disease, when they're symptomatic, consistent with the NCCN guidelines, and when you get a scan and it looks like there's rapid growth, because suggesting the tempo is picking up. And in those patients, in terms of your practical clinical experience outside of a clinical trial, those are the ones that I look in terms of thinking about switching to a new therapy. I have several patients who, they have a great response and then they plateau to these EGFR inhibitors, for example, and you get a scan, 2 months later, and there's 1 millimeter or 2 of growth. And I've had some going on for a year or so, where each scan there's like 1 millimeter or 2 of growth, but over a year it's maybe half a centimeter or a centimeter. Those I typically follow and just just follow them closely with scans and watch them very carefully for symptoms. So those are the main things that I look at: symptoms, tempo of disease, and bulk of disease. And I think the majority of oncologists look at those as well in terms of making practical day-to-day decisions for patients outside of clinical trials. The Osimertinib for the treatment of T790M positive non-small cell lung cancer has changed the paradigm in terms of looking at resistance mechanisms at the time of progression on erlotinib, afatinib, or gefitinib. These approved, first-line EGFR TKIs, and because it has a response rate of about 60%. And a median progression-free survival of 9.6 months, which really highlights the clinical activity of this drug in patients with EGFR T790M positive non-small cell lung cancer. We know that based on the clinical trials, if they're T790M negative, the response rates and the progression-free survival is much lower. It's not as clinically active. So, now that we have a treatment to match to the T790M mutation, it's become essentially standard of care, and that's reflected in the NCCN guidelines. To take a look at the mechanism of resistance at the time of progression to try to match to this drug. So previously, these resistance mechanisms were mainly looked at as part of clinical trials and more academic questions. But now that we have an approved therapy, it's really changed and evolved to standard of care.